On behalf of NAARI division of Jagsonpal Pharma, we welcome you to the next in the series number 10 of Inspire and Ignite Ultrasound, our third eye. This series is organized by ISAR Haryana. We welcome all the delegates and all the faculty to the webinar today. Jagsonpal presents to you Cystelia M, formulated with the ideal 40:1 ratio of myoinositol and D-chiroinositol to restore ovulation and reproductive health in women. Lycored M tablets of natural lycopene fortified with N-acetylcysteine enriched with CoQ10 and L-carnitine. For added advantage, to win the race, Lycored M contains two proprietary complexes, natural lycopene as lycobeads from Israel, and L-carnitine and L-tartric acid in ratio of 2:1 to give highest L-carnitine as Carnipure sourced from Switzerland. We also bring Endoreg, pioneers in tablet formulation of Dynogest 2 mg for endometriosis. A warm and hearty welcome to all the esteemed faculty and attendees. Please note, this webinar is streaming live on Facebook and the link is being shared in the chat box. To refer to this webinar in future, you can visit our YouTube channel, Jagsonpal Medical Insights. Now we invite Dr. Jyoti Malik, Chairperson, Haryana Chapter of ISAR. She's Director Roots IVF at JJ Institute of Medical Science Services, Bahadurgarh. Please initiate the program, ma'am.
Yeah, thank you so much. Thank you, Jagsonpal, Dr. Deepika, for giving us the opportunity and the platform to interact with our ISAR Haryana faculty as well as the attendees. And this is our 10th series, and we, with the ISAR Haryana motto of Prayas Evam Vistar, we have been trying to attempt to learn more, to join with everybody on this platform with all the members of ISAR Haryana, and we are definitely making big progress and a big vistar. So welcome everybody, and today this is our 10th webinar on, and this is being hosted by the USG Ultrasound Committee of ISAR Haryana, where Dr. Isha Narula is the chairperson for this committee for us. So we have various committees, and every month every committee does their webinar, and this month goes for the ultrasound committee, and we have three wonderful talks on by this for this webinar, and we have wonderful speakers. We have the first talk on fibroids mapping by a great speaker by Dr. Ladbans Kaur ma'am. Then we have a second talk on Mullerian anomalies by Dr. Isha herself, and the third talk is by another great speaker we all know. He is national and internationally known, by Dr. Kuldeep Singh, on the Doppler on infertility. So just a brief this thing to talk about how ultrasound is actually the topic today is ultrasound is the third eye, our third eye. And that is why we as infertility specialists need to know our ultrasounds and to do our ultrasounds ourselves. And briefly, how we took up this topic of fibroids, how they cause infertility is by a number of ways, judged by their mechanical distortion. The submucosal ones, they grow into the cavity, affect implantation. The intramural ones, even they might not be impacting on the cavity, but just by their presence and by their size, they may affect the uterine contractility. By their position, they may affect the tubes, and they may even affect the local endometrial environment, cause inflammation, vascular changes, hormonal disruption, and cause, if previous surgery of fibroids has been done, it may lead on to adhesions, inflammation, intrauterine adhesions and all. So thereby we need to be very careful whether we need to operate on this fibroid or not. And if we are operating, we need to map that fibroid. So Dr. Ladbans ma'am is going to tell us in detail about the mapping of the fibroids. Then the second thing that we are going to talk today is on the Mullerian anomalies, and there are malformations due to improper fusion or resorption. So anything can happen. If there is improper development anywhere on the fusion, we have certain defects. If there is a defective resorption of these Mullerian or the paramesonephric ducts, then it causes different sort of Mullerian anomalies, and it can be sometimes very, very confusion to us how to differentiate between a septate and a biconjugate uterus. So I'm sure with the 3D and with the detailed knowledge of the 3D ultrasound, we can always be very sure what we are dealing with. And I'm sure Dr. Isha is going to throw a light on all this matter very nicely. And the third topic that we have is on the Doppler by Dr. Kuldeep Singh sir, and he is a master. And the number of times we listen to Doppler, we always find something new to add to our practice. So I'm sure we all are going to enjoy today's session. It's going to be very pertinent. And now with my team with the secretary, Dr. Meenu Handa, with the clinical secretary, Dr. Manju, and Dr. Lakshmi as the treasurer, we bring to you this webinar, and this is all with the blessings of our national leaders. We have Dr. Amit Patki sir, who is the president of our national ISAR, and he is always there to guide us, to help us, and to give us ideas. He is the medical director of the Fertility Associates Mumbai, and he's also a consultant at Khar Hinduja and Surya Hospitals, Mumbai. Sir has many publications and many chapters. He's an international figure, and he is always a great guiding force, along with our secretary, Dr. Asha Bakshi ma'am, who's our friendly, very, very close and very warm person, who's now the Secretary General of ISAR, and she is a lead consultant at Dr. Asha Bakshi Fertility Center at Indore. So with their blessings and with my team, I hand it over to Dr. Lakshmi, who is a consultant at Cloud9 Hospital, Faridabad, and she has her fellowship in reproductive medicine, and she is presently the treasurer of Haryana ISAR, and she is the master of ceremony today. So we can start. Dr. Lakshmi, I hand over to you so that we can start the session now. Thank you.
Thank you, Dr. Jyoti. So we are all very excited to start today's session on ultrasound. For the first session, which is on uterine cavity, a glimpse to the etiology in infertility, I would like to invite our chairpersons, Dr. Anjali Bansal, Dr. Anika Goswami, Dr. Divya, and Dr. Meenu Deswal. So we have our chairpersons in the meeting, and we will have their comments in the end of the talk. And I would like to invite our speaker, Dr. Ladbans Kaur, for the first session. Ma'am is the director and the consultant radiologist and fetal medicine specialist at Prime Diagnostic Center, Chandigarh. She is pioneered in the region of transvaginal sonography, peripheral color Doppler, first trimester ultrasound, 3D, 4D obstetrics and gynae scans. She has vast experience in fetal diagnostics, fetal interventions. She has delivered more than 200 talks and deliberations on obs and gynae at various international, national, and regional conferences. She holds a key faculty position in ICUOG, approved advanced courses on endometriosis, ICOG approved course on one-stop series fetal first trimester, and ICOG approved Global Conference on Gynae Ultrasound. She has been awarded Best Paper Award for Oral Presentation at ICOG 2012. She has many publications to her credit. She has scientific association with ICOG, FMF, and with IFU, MD, and IRI. I now hand over to Dr. Ladbans, ma'am, for her talk. Thank you, ma'am.
Thank you so much for a very, very kind introduction. And at the outside, I'd like to thank Dr. Jyoti and her entire team and ISAR Haryana for having me over today. And very rightly introduced by Dr. Jyoti, who has really briefed about the use of ultrasound as a third eye in gynecology practice. So as the first talk of mine would be talking about the uterine cavity and its importance of how fibroids are going to impinge and the management of those fibroids. So with that, I would like to share my screen, and here I am. Yes. Okay. So that's fine. I think it's shared now. And you have my cursor, which is moving, Dr. Jyoti. All okay?
Yes, ma'am. We can see everything.
So, right. So I begin my talk on fibroid mapping. As we all understand that this entity, what we call as fibroid, will be seen in whosoever is attending 1 out of 4. So it's such a common entity which we see in and day out of our routine ultrasound, gynecological ultrasound practice. So what basically are fibroids are benign tumors of myometrium composed of smooth muscles and connective tissue. It is actually the transformation of normal myocytes into abnormal myocytes and is seen in as high as 40% by the age of 40 years. As far as the clinical presentation goes, about 2/3 of them are asymptomatic, whereas 1/3 of them present with heavy or prolonged menstrual bleeding in the form of menorrhagia and polymenorrhagia. Then, if they have a large size, they can produce bulk-related symptoms as pelvic pressure and pelvic pain. And then if you have the fibroids which are impinging upon the endometrial cavity, they will produce things like intermenstrual bleeding. Then they can also be seen in the form of large fibroid polyps, which could also extend outside the uterine cavity, and they rather are sometimes cause of partial or complete uterine inversion, as is seen very, very rarely. Then they do present with dysmenorrhea, and more than that, if we talk of their reproductive dysfunction, they are a very frequent cause for infertility, subfertility, and various obstetric complications also they can happen when you see them in the ongoing pregnancies. So our godfather, that is the Musa criteria, which helps us to actually define the various types and features of the fibroids. So this is how we have to actually describe the fibroids in such a way that what it means to me as a lesion when I describe it, it should make the same sense to the other person. So you have to speak the same language. It is exactly something, if I say a Labrador, you would naturally immediately figure out a Labrador dog in front of your eyes. So when I say Labrador, it means the same to me and the same to you. So before that, we begin talking about fibroids. It's a good practice to actually, when you scan the uterus, how do you bring out a certain checklist for yourself? So a certain checklist is, you would like to see the serosa. It should be smooth contour, hyperechoic contour. Then we'd like to see the myometrium. Is it homogeneous? Is it heterogeneous? Is it showing you a fibroid? So if we talk of myometrial lesion, is it an adenomyosis or an adenomyoma, right? Then we always try to look at the endometrial myometrial junction to make sure that it is smooth and hypoechoic and none of the fibroids are impinging or not impinging to that particular area. Then we also see the symmetry of the anterior and the posterior walls, which certainly gives you a hint for looking at adenomyosis. Apart from looking at the uterus, it is a good practice to have the complete view of the entire pelvis by looking at the uterus, adnexa, ovaries, and of course, to begin with, we always begin with looking at the introitus, vagina, and the cervix. So do not ignore these are not unimportant areas, right? They could be a cause for any other there's some kind of disturbance, Dr. Jyoti. Anyway, so there is these are the things which are need to be seen when you actually examine the pelvis. So before we actually start to know how do we map the fibroids, it's very crucial how to diagnose the fibroids. For that, there is a proper pattern recognition. And for this pattern recognition, we need to look into these particular areas which are looking at the echo texture. We would like to see, because we know the fibroids are well circumscribed hypoechoic lesions generally, but at times you may be seeing an isoechoic to hyperechoic lesions, right? So this is a fibroid which is showing you non-uniform mixed echogenicity, whereas they could also show you increased echogenic areas in a non-uniform background. Also, you could see the fibroids showing you irregular cystic areas, and or you could see a large area with completely degeneration that is telling you that this is a fibroid. So I am showing you a varied appearance of typical and atypical fibroids. So this kind of pattern recognition should always be kept in your mind to tell you that, yes, I am looking at a fibroid. And also, if not so typical, if atypical, I am able to go close to the diagnosis of that particular entity. Also, these fibroids, if you see, they will produce a typical edge shadowing. And also, they can show you edge shadowing and internal shadowing as well. In a completely calcified fibroid, they will produce a fan-shaped shadowing. So whenever you have a lesion, there is always a practice to spontaneously switch on your power Dopplers or color Dopplers, where fibroids will show you a classical pericapsular or perilesional flow, which is seen within the pseudocapsule formed by the compressed myometrial tissue. So this is a very, very classical feature which helps you to differentiate an entity which is called as adenomyosis, where an adenomyotic area will show you a translesional vascularity. Apart from looking at the vascularity, the features are you have an ill-defined lesion as against a well-defined fibroid. Also, they will produce a shadowing which is called as a fan-shaped or a rainforest or a Venetian blind-like shadowing, which is a classical feature of adenomyosis, as against a leiomyoma, which will produce edge shadowing or an edge on an internal shadowing. To go more further, leiomyomas will show you a swirled kind of an appearance, whereas adenomyosis will not show you that kind of appearance, because remember, adenomyosis is an entity where you have the endometrial glands insinuating the myometrial tissue, right? So they will produce heterogeneity. They will produce echogenic striations, buds, and cysts, right? So that's a talk in its own, but it's very important since we are talking about fibroids. The adenomyosis is another entity in the myometrium, and you need to know about its existence, one, and you need to know how you differentiate it from a myometrial lesion, and that's a fibroid. Also, to tell you that adenomyosis, since it starts predominantly in the endometrial area, the endometrium is generally ill-defined, right? Though it shows a normal thickness, whereas a leiomyoma the endometrium borders will be distorted but not indistinct, right? So that's another important differential diagnosis. To show you and make things more clear for you, as you are all gynecologists and you are operating, where you see a fibroid on a gross will show you a completely well encapsulated lesion as against an adenomyosis, which produces this kind of heterogeneity or this kind of, the fibers of the endometrium tissue insinuating between the myometrial wall. So once you look at this particular gross specimen, it gives you a further depth of knowledge of how an ultrasound would reflect these changes. So now we go to fibroid classification. So this is what Musa brought to us, that is the FIGO classification introduced in the year 2011, which was actually based on the relationship of these fibroids with the endometrium, myometrium, and the serosa. So the FIGO gives us wonderful classification, which tells us if you're looking at a FIGO 0, that means the fibroid is pedunculated, completely an intracavitary lesion. And if you're looking at a FIGO 1, that means it has a bearing relationship with the endometrium, it's submucosal, and less than 50% of its will be projecting into the adjacent myometrium. If you have a FIGO 2, it does have a small submucosal component, but a larger intramural component. When you're looking at a FIGO 3, that means you're looking at a intramural fibroid, that means within the myometrium, but shows you a mild indentation with the adjacent endometrium. And if you're looking at FIGO 4, it is completely intramural. FIGO 6 will have a subserosal component, a mild subserosal, and predominantly seen within the myometrium, whereas a FIGO 6 will have a large subserosal component, and 7 is a pedunculated fibroid, and 8 is in the cervix. And there's another entity by which we call it as a transmural or FIGO 2-5 fibroid, or also called as a hybrid leiomyoma, where the figure 2 shows its relationship with the endometrial lining, whereas the 5 denotes the relationship with the serosa. So this is how the fibroids have been classified. So once you have a classification, it's easy to map. Your accuracy of mapping will increase when you know how to map, how to classify a fibroid. Dr. Jyoti, everything going on fine, please?
Absolutely, ma'am. Wonderful. Wonderful.
Okay. I just, I thought probably some internet glitches or not. Anyway,
Ma'am.
so we take it further. Why is mapping important? Why are we laying such a lot of stress on mapping? Why do we want that we as radiologists or people who do ultrasound should map things properly? Because it is very important to know if the fibroid is the cause of the symptoms. So I'm not a clinician, but I know I always take a history to begin. If she's symptomatic, I make sure that I look at the cavity nicely. It may not be always fibroid, it could be anything else, right? So I need to have, I should be vigilant, right? If I know an entity, I will see it. If the mind doesn't know, you will never see it, right? Second is that this information of that whether a lesion is causing symptoms actually is going to help you define a management, right? Your management decision is going to change once you have a physical lesion within the endometrial cavity. And also if you have the presence of the fibroids, after you are mapping properly, you will ensure that there is complete removal. If you map the fibroids, let me tell you, the surgeon is at complete ease because he is or she is going to remove the fibroids according to how you map it. So that's the importance of mapping. So what else how do we go about it? We not only look for location, right? As I've already told you, it is going to impart upon the treatment options, right? Whether to go hysteroscopically, whether to go laparoscopically is all going to be determined by location of the fibroid. Then we also check out the number. We also check out the size, right? Then we also look for the penetration into the endometrium and myometrium, and also look at the fibroid morphology, because there could be some atypical lesions. Today only I did a case. In fact, I should have added that video. It was reported as subserous fibroid for a number of years, and that was not a fibroid, and it was a focal adenomyoma. See, it's very, very important to see the morphology of the fibroids. There are certain morphology atypical fibroids which could be alarming, right? Which could tell you that, yes, I'm not looking at a normal looking fibroid, and this demands attention because this will come directly as grade 4 spread of metastasis. These are the women who present with metastasis, and nobody takes care to see the morphology of these fibroids, right? That's, of course, besides the point. So relevant 2D and 3D images are very, very important once you start mapping. What are the parameters used for fibroid mapping? Yes, this is a section to show you the sagittal section of the uterus. Now, either it could be a superior location, it could be in the mid corpus, it could be in the lower corpus, or it could be in the cervix. Then we try to see on a transverse section, is it an interiorly located fibroid or a posteriorly located fibroid or in the lateral wall? Then we also try to see whether it's in the right side, or left, right, or in the midline. So these are an important messages which you are trying to tell the surgeon that how the location of the fibroid is. Then we also try to tell whether the fibroid, how close it to the endometrium, how close it is, or how much is the distance of the fibroid from the serosa. Because if it is more, then naturally you will go hysteroscopically. So as compared to the other type. So this is going to, all the information is going to summarize and help the surgeon to go about this particular case. So what is the ideal time to map the fibroids? It's the secretory phase. Naturally, we do understand that they would cause a good contrast with the secretory phase of the endometrium. But yes, I mean, it's not hard and fast. Sometimes you may have a lady coming with symptoms and you have such a kind of fibroid. And believe me, you don't need a thick or a hyperechoic endometrium. Your answer is there, already sitting on the wall. What are the various modalities to map the fibroids? It could be just 2D. You could resort to 3D, right? Sometimes there are lesions which may not be apparent. You can use a saline infusion hysterosonogram, but an MRI should be your last resort. We are radiologists, sonologists. You try to use all your maneuvers before you ask for an MRI. I do not say that MRI is not useful, but let's do a good ultrasound first, right? So 2D mapping, by 2D mapping, we understand, like if you're looking at this number of fibroids, about say 3 or 4, and I'm sure if this is a sagittal view and a transverse view, you move your probe from right to left in a sagittal section and up and down till you stop seeing the fundus or stop seeing the cervix in a transverse plane, you will be able to map the fibroid even on 2D, right? Then there could be challenging situations. Like in this case, you have an enlarged uterus which is studded with fibroids. How to answer this lady? How much to report? Which one to report? It's a very confusion. First of all, how to see whether it's uterus, whether it's the whole of his fibroid. So the clue is, go from the cervix, fill up the bladder, try to trace the cervix up, right? What is important is the endometrial lining. How will you see the endometrial lining? Till you are guided by the cervical canal, right? You have an echogenic cervical canal, follow it up into the endometrium. Many a times we face problems. This is still better. You could have a distorted endometrial lining and you're confused, right? So you follow the cervical canal up towards the fundus and you are going to see how much or how many of the fibroids are bearing a relationship with the endometrium. So that's the basic thing which we want to, because those are the ones which are going to be symptomatic. How does 3D help? 3D helps to give you a C-plane, a plane which is not seen on 2D, right? So it helps to show the fibroid in the coronal plane or the C-plane or the 3D reformated plane, then helps to assess the relationship of the fibroid here with the endometrial cavity. And once you have the relationship, you can rate the submucosal fibroids, where this classification, the Lasmer step W classification, has put forth these 4 parameters which help to classify the submucosal myomas, where it tells you about the size, topography, extension into the base of the myoma, and degree of penetration into the wall. And each parameter receives a score. Total sum of them indicate the type of the myoma and complexity of the therapeutic procedure. So if you have a score of 7 to 9, that is, that is a score which tells me that the operating physician will have to, the lady will have to undergo a complex procedure. Of course, there is another classification, almost the same as FIGO, but only thing different here is the angles which they have put forth. The angles are the acute angles, which is seen in L1, right? The SK gave this classification, that is European Society of Gynecological Endoscopy, which tells you if the angle is acute, that means you have type 1, L1. Dr. Jyoti, there's
Deepika,
some,
yeah,
there is
Dr. Deepika,
somebody
can you please mute everybody? Please mute everybody else except Dr.
Yes,
Lal.
ma'am.
Thank you.
Okay. So then if you have an obtuse angle, that means I'm looking at a fibroid which has less component which is inside and a more intramural component. So that's just one of the classifications, right? So now we have actually seen, all of us, we have seen 3D pictorial views. We have seen these images. We are all well versed that how 3D has brought in light to build up the entire types and looking at all the features, how they can reflect it on a 3D reformatted image, how they can help us in management. But today, there is a journey of the fibroid which I will just like to share. We've gone from 2D to 3D, and now what we have is 3D AI. And now this 3D AI helps you to show you these kind of pictures. But believe me, these kind of pictures begin with 2D, right? Your 2D has to be good. You can't say this is not jadoo, right? That suddenly you will put the button on and you will get these images. No, you have to be good. You have to be systematic on 2D. Once you're systematic and then you use your 3D, you can bring out these pictures, right? And this will tell you whether I'm looking at a transmural. Even in 2D, you can make out. It is just the relationship of the endometrial cavity with the fibroids will be better broadcasted here, better informed. Sometimes it gives you better information than 2D, right? Sometimes there is a fibroid which may be very, very challenging, in a situation where 2D is better. For example, interior wall fibroids, where if your green line, the 3D reformatted line which you use in doing your 3D does not pass through that, you will not see the fibroid, because that green line represents the endometrial cavity, where this AI has brought you a step further. I'll show you how we do it. This is how the things are done, though they are still images. You just see this particular fibroid, go ahead and we switch on the 3D button. We trace out the area of the fibroid, and automatically the machine will give you the contour of the uterus as well as the endometrial cavity. So we take our cursor up and say, yes, this is the fibroid we want to see. And as we click upon the region of the fibroid, whether it's in A plane, B plane, or C plane, automatically this is the image or the reformatted image which we get on a 3D. So this can be done with multiple fibroids if seen other than an isolated one. So coming to MRI, I don't say that it's highly sensitive. Let me tell you, it's very sensitive at times when you have lesions, multiple lesions. They say more than 375 in one of the articles, but believe me, 375 ml is not that much, right? 5 myomas is not that much. But if the uterus is riddled with fibroids, there are areas of adenomyosis, then it becomes a little challenging, because each and every one of us is in a phase of learning, right? So if you have problems, yes, it's a very good tool, provided it is done with an expert. Again, it needs, expert, and it's not a very freely available, and, it's not very cheap also, and not very handy, right? So all these disadvantages and advantages of an entity must be known, and we must trust our ultrasound. So fibroid mapping can be also done, for example, in this particular case, which comes to me for an intermenstrual bleeding for 7 months, and this is the thickened endometrium I saw. Now, I wanted to see the lesion. The endometrium is thick. I'm unable to discern a lesion in this lady. I am going to instill fluid. And believe me, instilling fluid is very basic. As we do our HSGs, we just take a, HSG catheter, and we, block it. We infuse, like the Foleys, we infuse a little bit of fluid, and it is held just above the internal os. Maybe once it goes ahead, you can withdraw a little, and we instill fluid, right? And moment you instill fluid, and believe me, this thing comes up, right? This was a large fibroid polyp. So these are the things which can be done when you don't get your answers. Remember, you have to find your answers. And if at all you don't find your answers, then only you say, okay, yes, it could be hormonal. Physical cause needs to be excluded every time. Let's have a look at few case studies. That's Lily. Lady comes to me with heavy menstrual flow and secondary amenorrhea. So what is the FIGO like? The FIGO is that I do see a fibroid within the cavity. I've done an omni-view, and an omni-view, I see the fibroid is going a little closer to the uterine wall. I'm scared. If I go hysteroscope, I must inform the surgeon that, I don't see much of the myometrial rim. Why? Because less than 0.5 mm, I know the surgeon there are chances of perforation, right? So these are the things which I need to bring out and in the best to the surgeon. How do we do it? We draw a line from one endometrial junction to the other endometrial junction, and completely perpendicular to it, I draw another line, and I get two A and B. So as you see, the B portion of the line is more than A, and if it is more than A, what am I looking at? I'm looking at a FIGO 2, right? So less intracavitary component, more myometrial component. So it gives me a FIGO 2. As against, I see, if I draw a line here, and I draw another line here, and I know my red component is more. So this makes a FIGO 1 classification. So this is how you need to know. You may not draw a line, right? You may not draw a line. You just figure it out, right? At least you can subjectively analyze it. If you have a problem, go and draw a line. There's no problem, right? So now there could be fibroids safely seen within the uterine wall, but they can enlarge. They can enlarge and distort the cavity, as well as reach up to the serosa, and what you call it as transmural fibroid. Then this is to show you a fibroid, which a lady who had come with bloating of the abdomen, discomfort, pain, and this was diagnosis which was suspected of an adnexal tumor. I went in, did an ultrasound, transvaginal. I saw the uterus is normal. Her right ovary, left ovary is perfectly normal. So where is this tumor coming from? Going further, I did see a large lesion showing you multiple cystic areas within it, looking very dangerous, right? There was a bit of fluid also, but what caught my attention? So I know my uterus is normal, my ovaries are normal. I am going to search for the organ of origin of the mass. This is very crucial, right? Iota says must ascertain the organ of origin. So the organ of origin has to be ascertained, and this gave me the lead, and these are the bridging vessels, and I was looking at a large subserosal fibroid showing degeneration and mimicking an adnexal tumor. And another advantage, always when you have a large lesion, it's a good practice. Either you start with a good full bladder. This lady was in pain. I was wondering that she had probably had a torsion. So I went in transvaginally, but later on did a transabdominal ultrasound to show you that how well you can ascertain the volume of the mass transabdominally, how well you can ascertain globally the entire pelvis. So there is an advantage of doing a transabdominal and followed by a transvaginal ultrasound. And this color Doppler also shows you the bridging vessels. I'm almost going to finish, doctor. So this is another lady, very atypical presentation of a fibroid, right? That's the area, that's the lesion where I'll just show you, that's the lesion, right? Just keep on watching the video. What you see here is a large heteroechoic mass, right? This mass is showing continuity with another mass here. Rather, it's breaching the endometrial myometrial junction and extending into the entire endometrial cavity, taking it further down right up to the cervical canal. So this lady was having menorrhagia, dysmenorrhea for the past 6 months, varied reports, right? And this was actually a fibroid polyp. It was a submucosal fibroid. Why? Because sometimes we may not be able to actually do a correct figure for this, right? So this is something where a fibroid takes a least resistance, right? We know that it has the ability to take the least resistance, and this is how it started its origin in the myometrium and breached on to the cavity and extended within it. And this was the kind of vascularity which was seen within this atypical fibroid. And look at the 3D reformated images and taking it down. That was the gross cut section as they did, took out the uterus, and that was the sectioning. And the moment the doctor will, show us the intramural component, right? Showing you the intramural component and the extension of this entire thing within the cavity. So this is a good learning, right? This is how you learn from your gross specimens. So finally coming to the reporting, the last part, you have to talk about the uterus, give the size of the volume of the uterus, because in case you're going to put this lady on medical therapy, will help you further. One. Second, you talk about the myometrium, serosa, symmetry of the walls, echogenicity, and finally coming to the fibroids, location, number, etc., which I've already dealt in good detail. You can also add a diagrammatic representation of these fibroids. You can just take a small paper and sketch it out. If you have a report, you can just sketch it out, transverse section or a uterus. I mean, this gives you, this will reflect a better you will understand the things better, and so will your doctor. So this is just to tell you that if you have a riddled uterus with multiple fibroids, remember the submucosal fibroids must always be reported, whereas the non-submucosal fibroids, at least 4 of them, should be mapped and reported. So thank you so much for a very, very patient hearing.
Thank you, ma'am. Thank you for such a wonderful talk. I would request our chairpersons, Dr. Divya.
Yes, Dr. Lakshmi. It was indeed a very good talk.
Yeah, Dr. Divya.
I don't know, my video is somehow it's not started. Yeah. So it was almost
Yes, yes,
Dr.
we can
Ladbans.
see
She
you.
has covered, yeah, she has covered everything. But for it's very important fibroid mapping, as we all know, as we all are infertility, like we are practicing ART. And sometimes we need to know how, especially in cases of submucosal fibroid or a fibroid polyp, because that is going to interfere with our result. So that was the part. I think you covered it so well. But one thing I will like, what is the, I mean, how to differentiate between a polyp and a submucous fibroid? So that was one thing I will like Dr. Ladbans, to show a little light, since most of us, we are doing our own scans. And when we are doing, already we have a history in our mind. So most of the time we correlate with it. But sometimes if it is a small file, because it has come as a surprise in my practice. I had put a hysteroscope with the thought that it is a polyp. And then when I have started cutting with my scissors, then I have a lot of resistance and I have taken it out and then sent for histopathology. It comes out as a like fibroid, as a small fibroid. So that is one thing I like to throw a little light upon.
So you want me to differentiate? I tell you what
Yeah,
are the...
yeah.
Okay,
Just
yes.
if
Right.
I think if
No,
Dr.
not
Lakshmi and Dr. Jyoti, they allow us.
so, okay. If it's okay, I'll just go ahead. So what do we see in polyps are? These are uniformly echogenic lesions, right? And a polyp will
Okay.
always have a pedicle artery, right? It always should put on your color
Most
Doppler,
of the time, yeah.
right? Most of the time,
Most of
right?
the time they have, right.
Yes. And most important is when you switch on your power Doppler, you never use color Doppler, always use power Doppler, right? Because that will pick up the small little flow or less flow within the small vessels, right? Try to rotate your probe, okay? You may not
Okay.
sometimes see it in one section. Try to
Okay, you
rotate
have to
your
take
probe.
multiple, yeah.
Yes, try
Sagittal,
to rotate
transverse
it.
like
Moment
that.
you see
Okay.
an endometrial polyp, switch on your power Doppler. In case you don't see, you are sure you're looking at a polyp, rotate your probe. The moment you
Okay.
rotate your probe, you will see a pedicle artery either coming from the right side or the left side. So that is one tip to
First
actually
point.
bring down your PRF to 0.3, right? That's where you have to do your gynec scans, right? Two, and very importantly, if you actually see a polyp, it will always be an echogenic area. It will deviate your midline, the
Okay.
endometrial midline. Yeah, that's one catch for a very, very important sign of an endometrial polyp. Whereas if you see a fibroid, you may have an echogenic fibroid too, but generally they are hypoechoic.
Hypoechoic,
It's a
right.
muscle, it's a connective tissue. They're generally hypoechoic or a mixed echogenicity, may show you calcification or a tiny foci of calcification at times, not always. Then, when you put on your power Doppler, they will show you a circumferential flow as against, or even if you have a tiny little twig of vessel coming from the adjacent myometrium, it will try to encircle it. That's the difference. So that's how you differentiate on ultrasound and power Doppler a submucosal fibroid from an
From a
endometrial
polyp. Thank you so much. And very well explained again. I think we all are going home with this tip, and that is definitely going to enhance our practice.
Hopefully.
So thank you. Thank you, Dr. Jyoti. Thank you, Dr. Lakshmi.
Thank you.
Thank you. We have other chairpersons as well, Dr. Meenu Deswal, Dr. Anika, if you want to comment. Dr. Meenu, you are on mute. Please unmute yourself.
Good evening, everyone.
Please unmute.
It's always an academic treat to listen and learn from you, ma'am. And thank you for such an informative and very crystal and crisp talk. Thank you so much.
Thank you. Thank you.
Thank you, ma'am. It was indeed a very good with lots of tips and tricks. It will really help us in our practice. So we move on to our next session. Thank you again, once again, ma'am.
Yeah,
So,
thank you so much, ma'am. Thank you. I mean, we knew there are something, I mean, even that small tip that you've given today of
Yeah.
rotating the probe is going to give us so many new more diagnoses of polyps and will clear out the diagnosis.
And one more thing, like listening all the take home points, like for us, we most of us are gynecologists, I suppose, and it's always good to hear you and to know that what we are doing is right. So that is like putting a seal on our practice also, because we know so many things, but we don't know much more things.
You know
Mm-hmm.
And
much more than
it
us. You
was
do
really
such...
very
You're a
no, it was
gynecologist.
very
I mean,
enlightening, like simple tips. You see the vagina and then the cervix, and then when once you are seeing right from the cervix to the top of the fundus, so that is the right section, and then you need to put your probe in the transverse diameter. So these are little things, but it's like a drill for us. So
Dr.
going
Deja, I
back
think
home and doing everything the same way you have told is like putting a seal on whatever we are doing is good, is right.
thank,
So
thank
that
you
was
so
really,
much.
really very important, ma'am.
Thanks for your
Thank
comments,
you
but
once again.
I think it's all passion driven. It's all passion driven.
Yeah.
I feel it that way.
But let's, get more motivation from your passion.
Yeah.
Yeah, thank you
Thank you.
so much, ma'am. Thank you for your time and
Okay,
for the practical tips, and it was an amazing talk.
Thank you, Dr. Jyoti, for having me. Thank you so much.
Yeah.
Thank you once again, ma'am. Now we move on to our next session. For the next session, I would invite our chairpersons, that is Dr. Deepika Jindal Agarwal, Dr. Niharika Sharma, Dr. Preeti Moon, and Dr. Rakhi Malhotra. So the next topic is the Mullerian anomalies, and the speaker for our topic is Dr. Isha Narula. Yes, so Dr. Isha Narula is a ex-SR from AIMS Delhi. She's a fellow of fetal medicine, diploma in clinical and fetal genetics, and she's a fellow in MSK ultrasound, chief of fetal medicine and genetics and women's imaging at Narula Diagnostic Center, Rohtak. She's regularly doing antenatal ultrasound, fetal echo, fetal MRI, amniocentesis, and women's imaging. She's delivered many national and international talks, and I now invite Dr. Isha Narula for her talk on Mullerian anomalies. Over to you, Dr. Isha.
Thank you, ma'am. Thank you, Dr. Jyoti, for giving me this topic for presentation. Can I be discussing about the congenital uterine malformations today? No. This is let us begin with first image. That is, it is a case of a 30-year-old female who presented with 6 months of secondary infertility and had a history of missed abortion at 2 months of gestation 2 years back. And there is no other menstrual complaint. So this is a mid-coronal 3D ultrasound of the uterus. And many times we get confused now whether it is a normal uterus, an arcuate uterus, septate, or a bicornuate uterus. For some people, it is very easy to identify. For some people, it may be difficult. So as we proceed through our talk, I will try to make it easy how to identify whether it is a septate uterus or a bicornuate uterus or a normal uterus. So just a brief about embryology. Now the female genital system, it develops, as we all know, from the two Mullerian duct. One is the right Mullerian duct and the other is the left Mullerian duct. It develops around 6 weeks of gestation. And as the gestation advances, around 7 weeks of gestation, the two Mullerian ducts, they come and they unite to form a common duct caudally. The caudal part of the Mullerian duct, it fuses, and the proximal part of the Mullerian duct, it does not fuse. Around 12 weeks of gestation, the septa in between the two fused Mullerian duct, that resorbs, and it leads to the formation of a uterus, cervix, and upper 2/3 of the vaginal cavity. The non-fused portion of the Mullerian duct, that leads to the formation of the two fallopian tubes. The ovaries and the lower third of the vagina, that does not develop from the Mullerian ducts. So the congenital uterine malformation, as we proceed, can occur in any phase of this embryogenesis. Either it can occur during the duct formation, or it can occur during the duct fusion, or it can occur during the septal resorption phase, and it leads to different problems. So first, coming to the organogenesis or the development of the two Mullerian ducts. Now, as we know, there is a right Mullerian duct and there is a left Mullerian duct. So if both the ducts, they fail to develop, then there will not be a presence of any uterus. There will not be any cervix and upper 2/3 of the vagina. But as we know that the ovaries, they develop, they are independent of the Mullerian duct, and the lower third of the vagina, that is independent of the Mullerian duct. So we will get absent uterus, absent cervix, and absent upper 2/3 of the vagina with the normal looking ovaries. So that is MRKS, that is Mayer-Rokitansky-Kuster-Hauser syndrome. So this is when both the Mullerian ducts, they fail to develop. The second is when there is one Mullerian duct agenesis is there and one Mullerian duct is present. So it will lead to the formation of the unicornuate uterus, as there is only one Mullerian duct. The third problem which can occur during development phase is that one Mullerian duct is normal in size and the other Mullerian duct is small or hypoplastic. So what we can get is a unicornuate uterus with the other horn as a rudimentary horn. Now the rudimentary horn, it can either be communicating with the main uterine horn or it may not be communicating with the main uterine horn. And also it may have its own endometrial lining or it may not have its own endometrial lining. So if it has its own endometrial lining, we call it as a functioning rudimentary horn. If it does not have its own endometrial lining, it is called as a non-functioning rudimentary horn. If it is communicating with the main uterine horn, it is called communicating. If it is not, then it is non-communicating. And each and every entity of this rudimentary horn has its own problem. Like if it is a non-communicating rudimentary horn, but it has its own endometrial lining, that is, it is functioning, it may lead to the problem of endometriosis as the blood may accumulate during the menstrual phase. If it is functioning and communicating with the main uterine horn, then a GSAC can go and implant into this rudimentary horn. So and as we all know, since it is a rudimentary horn, the pregnancy will not survive into this. So we have to terminate this pregnancy. If it is non-functioning, it is not of much of a problem to the patient, and it is not, as it is non-functioning and it is not communicating. So we need not do anything for this rudimentary horn. So these are the problems which can occur during the development phase of the uterus. Then the next is during the fusion phase. As I mentioned that the caudal portion of the Mullerian duct, they fuse and the proximal portion does not fuse. So it can either be that there is partial fusion of the Mullerian ducts or they may not fuse at all. So if the Mullerian duct, they fuse partially, it leads to the formation of the bicornuate uterus. That is, we may have two endometrial canals, either just proximally or through and through till the cervix. And if the fusion does not happen at all, then it is the uterine didelphus. That is, we have two uterine cavity, two cervical canal, and two upper 2/3 of the vagina. They are also separate. So this is the anomaly which can occur during the fusion phase. And the last is the resorption phase. That is, when this intervening septa that does not resorb, that it leads to the formation of a septate uterus. So it can also be partial septate uterus. If the septa does not resorb at all, that is, it is involving the uterus, the cervix, and the upper vagina, it is called as a complete septate uterus. If it resorbs partially, then there will not be septa in the cervix and in the vagina or part of the uterus, and it will only be there in the fundal area. Then it is called as a partial septate uterus. So these are the congenital uterine malformation which can occur in different phases of development. That is during the organogenesis, during fusion, and during resorption. So most of these problems, as I mentioned, are mostly asymptomatic, but every problem has its own, every anomaly has its own problems. Like we just mentioned that for the unicornuate uterus, it may lead to the problems of endometriosis or the ectopic pregnancies in the rudimentary horn. Then it can also lead to the increased risk of malpresentations and preterm labor because the uterus itself is small in size. If there is a septate uterus, it reduces the chances of fertility and it increases the first trimester losses. If the GSAC implants at the septal area, then it is difficult for the GSAC, the pregnancy to continue because the septa is usually non-vascular. So now once we have known that these are the congenital uterine malformations which we need to consider while we are doing the scanning. So the next step is how do we diagnose these malformations? What modalities we have with us and our hand to diagnose it? We all know that the HSG, ultrasounds, and hysteroscopy, they are the three main modalities which can diagnose these anomalies. HSG and ultrasound, they are the first line modalities. Either it can be hysterosalpingography or a sonosalpingography. On HSG, this is the normal HSG in which we can see that there is a triangular shaped endometrial cavity with the bilateral fallopian tube, which is patent on patency. And so the point to be noted is that the endometrial cavity is triangular in shape and the internal fundal lining, that is usually horizontal. This is another HSG in which we can say that as compared to this with triangular shape, this cavity has an internal fundal indentation. So now this internal fundal indentation that can be occur because of septate uterus or a bicornuate uterus or an arcuate uterus. On HSG, it is slightly difficult for us to tell whether it is a septate or a bicornuate uterus, but more or less it looks like a septate uterus. Then this is the third HSG image in which we can see that the uterine cavity is very small in size. It is like a banana shape and it is deviated on one side of the pelvic cavity, and we can only see the one fallopian tube arising from it. So this is a unicornuate uterus. So many times it is very easy on HSG also to identify the anomalies. Sometimes it becomes difficult. And also HSG is usually the ionizing in nature because we are using radiations. So if possible, then the best modality which we can use to diagnose these anomaly is the ultrasound, and that too a 3D ultrasound as mentioned before also by Dr. Ladbans Kaur. So 3D ultrasound, the mid-coronal section, that is the best modality to identify the congenital uterine anomalies. This is a normal 3D ultrasound image in which we can again see that this is a triangular shaped endometrial cavity. The outside is the fundal lining or the outside fundal, external fundal contour, which is usually convex in shape. And this is the normal myometrial lining with a well-defined endomyometrial junction. So this is another image of this patient. This is the same ultrasound, 3D ultrasound image of this patient, in which we can see again that there is an internal fundal indentation and the external fundal outline. This is the external fundal outline. It is convex in nature. So we have to remember that if the external fundal outline is convex, it is either a normal uterus or a septate uterus or an arcuate uterus. So on this ultrasound image, we have ruled out that it is a bicornuate uterus. So it is a image of a septate uterus, and we can see that the proximal portion is the scar, the septa, which is the muscular in nature, and the distally as we go towards the cervix and the lower uterine segment, the scar has become fibrous scar, and it is easier to cut the fibrous scar as compared to the muscular scar. And this is the ultrasound image of the unicornuate uterus. So now how do we acquire this 3D ultrasound image? As Dr. Ladbans has already told, we have to take a mid-sagittal section of the ultrasound. When we insert the transvaginal probe, we take a mid-sagittal section and trace the endometrial lining from the fundal level till the cervix. And in every machine, we have a 3D button. So when we put on the 3D button, it will acquire our 3D multiplanar imaging. Then we switch on after this MPR view, we switch on the Omni view. And if we trace the endometrial lining in the Omni view polyline like this, we will get a mid-coronal image of the uterus. So it is very easy to obtain a mid-coronal section of the uterus, and then we are good to go to identify whether we have any uterine anomaly or not. Now the question is whether we should do this for every patient, or are there any pointers on the routine scan, on the routine 2D imaging that can tell us whether there is a uterine malformation or not. So the pointer towards uterine malformation on a 2D image is the splitting of the endometrial canal. As we can see here that this is right endometrial canal. This looks like a right endometrial canal, and this is the left endometrial canal, and in between them we can see the normal myometrial tissue. This is the normal myometrial tissue. So the endometrial canal has split into two, and there is an intervening normal myometrial tissue. So whenever we see such splitting with an intervening normal myometrial tissue, it should immediately raise our antennas that this is not a normal uterus, and we should go ahead, do a 3D scan of this patient and look whether it is a septate or a bicornuate uterus, as both the septate and the bicornuate uterus will give us the splitting of the endometrial canal. So once we switched on the 3D mode for all these three patients, we get different coronal images of the patient. So the first one, when I'll explain further, then we'll be able to identify whether it is an arcuate, a septate, partial septate, or a complete septate uterus. So on the 2D image, we get a suspicion, and on the 3D image, we get a confirmation whether which kind of uterine anomaly it is. Now, why do we need to differentiate between these unicornuate uterus, septate uterus, bicornuate uterus? Are their management different? Yes. So that is why, because they have different, each malformation comes with different class of problems and they have different management options. That is why it is very important for us to differentiate. So if it is uterine hypoplasia or uterine agenesis, which occurs during development, then there is no reproductive potential. And the patient has to undergo the gestational surrogacy in this case, and vaginal dilatation can be done for her normal sexual life. No medical intervention is possible for uterine agenesis or hypoplasia. If it is a unicornuate uterus with a non-communicating cavitatory horn, then it has to be resected because it is associated with dysmenorrhea, hematometra, endometriosis. If it is a non-communicating, non-cavitatory horn, it is not functional, then we need not do anything about it. Surgery is not recommended. If it is a communicating cavitatory horn, then also it has to be removed surgically because, as I said before, that the GSAC can implant in the rudimentary horn and it is rarely viable. So that is why we need to differentiate. If it is a uterine didelphus, then surgical treatment for the resection of the septa may be considered, but however, full-term pregnancies are very common in uterine didelphus. They usually do not have a much problem. In case of bicornuate uterus also, the surgical intervention is rarely needed. And in case of septate uterus, we have to resect the septa. Metroplasty is done for them and conception is possible 2 months after surgery. So since the treatment options are different, that is why we need to differentiate between these two. Now, there were various classification systems have been proposed to classify these uterine anomalies. The first system was given by American Fertility Society and the associate and the American Society of Reproductive Medicine. The most commonly used classification system these days is ASHRAE system. So the American Fertility Society gave the classification system of the uterine anomalies and classified into 7 types. The only limitation being that it only classified the uterine anomalies and there was no mention of the cervical and the vaginal anomalies. Next came the ASHRAE classification system. ASHRAE classification system, which took into account the uterine anomalies and the cervical and the vaginal anomalies also. So I'll be discussing ASHRAE classification in detail one by one. And after this ASHRAE also came the latest ASRM Mullerian anomaly classification of 2021. The advantage of this ASRM 2021 is it has a AI guided tool in that. So if we have any anomaly, we can just search this AI guided tool. It has classification, the associated variants which can be associated with a particular classification. It also gives us imaging, the treatment and the clinical presentation. So it is a very helpful tool once to know each and everything about the congenital malformations. And as opposed to American AFS classification, it has classified uterine malformations into 9 types as opposed to the 7 types which were given previously. So this is the normal 3D ultrasound image of a uterus. As I have explained before, triangular shaped cavity, the horizontal internal fundal lining, the convex external fundal contour, and this is the normal myometrium. This is ASHRAE class 0 or the normal uterus. Then the other is the T-shaped uterus, in which we can see that this is, as you can see here, that this is the normal endometrial volume. When we see here, we can all appreciate that the endometrial volume is reduced. The endometrial cavity is small in size and it appears to be T-shaped and there is increased myometrial thickening. So it occurs, the causes of T-shaped uterus can be diethylstilbestrol drug, which was very common previously, but it is not usually used nowadays. It can occur also because in adenomyosis, and it can also occur in tuberculosis. Now, does T-shaped uterus, whether it is actual T-shaped uterus or it is like our visual association, there is an objective criteria for it to define a T-shaped uterus, which was given by the Kuhn committee. It says that the lateral angle, which is the angle formed by the vertical portion of the endometrial canal and the lateral portion of the endometrial canal, if that angle is less than 130 degree, then it favors the T-shaped uterus. If the lateral depth, that is when we draw a line from the lateral, from the ostia of the fallopian, from the ostia till the lower part of the uterine segment, and we take a distance between the endometrial lining and this line. If it is more than 7 mm, then it favors the T-shaped uterus. As I said that because the myometrial has thickened in case of T-shaped uterus, and the T angle, that is between the horizontal portion of the endometrial lining and the lateral portion of the endometrial lining, the angle formed by the two, that is less than 40 degrees, it favors the T-shaped uterus. So all these three measurements, if it is lateral angle less than 130, lateral depth more than 7 mm, and T angle less than 40, it favors a diagnosis of T-shaped uterus. Then the next entity which has been described is uterus infantilis. Now we all know that normally the uterine body is 2/3 of the cervix. That is, uterine body is 2/3 and the cervix form 1/3 portion. In uterus infantilis, the uterus is small in size and it is 1/3 as compared to the cervix, which is 2/3. So that is called uterus infantilis. When the uterine body is, the ratio between uterine body and the cervix is 1:3. That is uterine infantilis. Then we come to the next entity as the normal and the arcuate uterus. In the normal uterus, we have seen that the fundal internal lining was horizontal. So when we get an internal fundal indentation, this is the internal fundal indentation, as we can all see. This is the internal fundal indentation. So when we get an internal fundal indentation, then three differentials comes to our mind, whether it is an arcuate uterus, it is a septate uterus, or a bicornuate uterus. So as we will, I'll proceed further, we'll come to the differential. So what we do is we draw a line from the interosteal line. We draw a line from one ostia to the other, and then we drop a perpendicular from the external fundal outline onto this line, and we drop a perpendicular from the interosteal line till the level of the internal fundal indentation. So if this internal fundal indentation, that is this depth, that is less than 1 centimeter, then we call it as an arcuate uterus. Also, we can see the angle between these two, between the two endometrial lines. This is the angle which is formed between. And if this angle is more than 90 degrees, then it favors the diagnosis of arcuate uterus. So we have to remember these 2 points. The internal fundal indentation less than 1 centimeter and the angle less than 90 degrees, that favors the definite arcuate uterus. Next is the septate uterus. Septate uterus is the most common of the Mullerian duct anomalies and is responsible for recurrent abortions. And treatment, as mentioned, is hysteroscopic resection. So again, how to diagnose? So for diagnosis of these 3D uterine anomalies, we always have to draw these lines, the interosteal line, and then we draw a perpendicular from the external fundal contour till the interosteal line, and from the interosteal line till the level of the internal fundal indentation. As we can see here that this internal fundal indentation is more than 1 centimeter visibly also, then it is more than 1.5 centimeter, it is septate uterus. The other method which is given by X-ray is it does not take into account the measurement. It takes into account the thickness of the muscle. So we see this thickness. This is the myometrial thickness. And this is the internal fundal indentation. So we take a ratio between the myometrial thickness and the internal fundal indentation. If this ratio is more than 50%, then it favors the diagnosis of the septate uterus. This ratio, the interosteal line we have drawn, we take this measurement from here to here. And can you see the lining, the arrows which I am drawing?
Very clearly. Dr. Isha, you are very, very clear and you are very slow also. We can understand everything. Very nice.
Slow because so as to make it understand, because if I'll go fast.
Yeah. Actually, if you go fast, we always, जब भी
Yes.
मैंने lecture सुना है, everybody goes so fast, we forget everything. So you are absolutely right and slow, and we are all with you.
Yes, ma'am. So we need to look at these two measurements. So if the ratio between these two is more than 50%, that is the internal fundal indentation is more than the myometrial thickness, it gives us a diagnosis of a septate uterus. So look at the external fundal contour, it is convex. The internal fundal indentation is more than 50% of the myometrial thickness. The angle of indentation, this is the angle of indentation, it is less than 90 degrees. So all these 3 points favors the diagnosis of septate uterus. So this is the muscular part of the septa, and as we proceed here, you can see that this is the fibrous part of the septa. So we have both a muscular septa and the fibrous septa here. So as mentioned previously, these are the two endometrial linings. This is the normal splitting of the normal myometrium. So once we see this image, this was a patient for the, this patient came for the pregnancy scan. And the moment we do the pregnancy scan, we see that the G-sac is implanted like laterally. It is not in the midline, it is implanted in the lateral portion of the uterus. And we see another endometrial canal here. So it should raise our antennas that it is not a normal uterus. It is either a septate or a bicornuate uterus. And the patient had intermittent spotting also. So once we do the 3D of the image, this is the right. The 3D image has come inverted. We can see that the gestational sac has implanted in the right uterine horn, and this is the left uterine horn. The external fundal contour is convex. The internal fundal indentation is more than 50% of the uterine wall thickness. So it is a septate uterus with a G-sac in the right uterine horn. And the patient had spotting because we have a functional left uterine the endometrial canal. Because of that, the patient had intermittent spotting. So now once the sac has implanted in the septate uterus, is it like all the septate uterus will abort or the pregnancy can continue? It all depends on the length of the residual functional cavity. So as we can see that these are the two cases. In the above case, the septa is only in the proximal portion, and this is the length of the residual functional cavity, which is left. In the lower image, we can see that the septa is deep and the residual functional cavity is less. So if the residual functional cavity is less, then there are more chances of the pregnancy to be terminated as compared if the functional cavity is more. So if the septa is longer, then the chances of pregnancy losses are high as compared to the septa being small. The also other thing which we need to see in case of a septate uterus is vascularity of the septum, because if the septa is avascular, then there is very less chances that the G-sac or the viable pregnancy can occur, as the fibrous septa will not be vascular. So when we use only this the myometrial thickness measurement, the diagnosis of septate uterus when compared with the SRM classification dramatically increased, and therefore this committee that is mentioned previously also, the congenital uterine malformation expert committee, it gave us the recommendation that instead of using the myometrial thickness, we should use these measurements, which I mentioned before also, that is the internal fundal indentation more than 10 mm, the angle of indentation less than 90 degree, more than 10 mm, and the external fundal indent contour, then it is a septate uterus. If the indentation depth is more than 10 mm, the indentation angle is less than 140 degree, and the 50% ratio, then it is the septate uterus. The ISUOG says only use the depth of internal fundal indentation, which is 10 mm. More than 10 mm, it is septate uterus. It does not say that we should look into the angles also. It just relies on the internal fundal indentation. And the ASRM says that the depth more than 15 mm and indentation angle less than 90 degrees. So every committee has a different measurement, but roughly if we take 10 mm, we are good to go. The internal indentation depth of more than 10 mm. So arcuate uterus, I have already told before, if this depth is less than 10 mm and the angle of indentation is more than 90 degree, it is an arcuate uterus, which we can easily see here. So always remember the lines which we have to draw. We have to draw an interosteal line, then we have to drop a perpendicular from the external fundal contour and from the interosteal line onto the internal fundal indentation. These three things we have to see very carefully. The next is the bicornuate uterus, which are usually asymptomatic and are usually diagnosed during the cesarean sections, and HSG, 3D ultrasound are performed. Again, we can see here that they are the two endometrial canals and the intervening myometrium is this. Now, in case of bicornuate uterus, since the two horns are widely separated, most of the times it is difficult for us to get a good 3D image. So this is a 2D of the coronal section on 2D only. When we rotated the probe, we can see a 2D coronal image in which we can see that this is the external fundal outline. This is indenting. Normally, we get an external fundal outline as convex like this. So the moment we see an external fundal indentation, we should think of the bicornuate uterus. Now there is a measurement for this also. So how do we say this external fundal indentation? Again, we draw a line, the interosteal line. And if this external fundal indentation is going beyond the interosteal line, it is definitely a bicornuate uterus.
Dr. Isha, this is the previous slide. This is the transabdominal scan or the transvaginal one? This is
Transabdominal.
transabdominal. The bladder is seen, na? Okay. Then only I think you can see the serosal indentation. This cannot be seen in transvaginal, I suppose.
Vaginal, when we get a 3D scan, when we acquire a 3D, then we can see the serosal indentation.
Okay.
When we acquire a 3D, coronal 3D, then we can see the indentation. So, as I mentioned, again, draw the interosteal line, and this is the external fundal indentation. If the external fundal indentation is dipping beyond the interosteal line, or if the distance between the external fundal indentation and the interosteal line is less than 5 mm, it is a bicornuate uterus. So here we are drawing this line, interosteal line, and this is the external fundal indentation. See the distance between the external fundal indentation and the interosteal. Or it is going beyond it, it is a bicornuate uterus. Then we come to the unicornuate uterus. I've explained all this before also. So this is a 3D of the unicornuate uterus, which is banana-shaped uterine cavity, which is small in size. It may be either deviated to the right or deviated to the left or maybe midline. So how do we get a clue of, many times I have seen that on a 2D imaging, the unicornuate uterus is missed. We just see the uterus, label it as normal, and when later during repeated scanning, we do a 3D ultrasound, or during HSG, we come to know that it is a unicornuate uterus. So when should we suspect a unicornuate uterus on a 2D ultrasound? That is when you are doing a 2D ultrasound, when we put either on a transabdominal scan or a transvaginal scan, if we are not able to see the uterus in the midline, usually we should be able to see the uterus in the midline. If we are not able to see the uterus in the midline and it is deviated to either right or the left, then it should raise our, and there is no other anomaly which is pushing the uterus, then we should think of a unicornuate uterus. So on a 2D, if we see that the uterus is small in size, it is not in the midline and is deviated either to the right or the left, and we are not able to see the normal 2 endometrial canals, it should raise our antennas, and then we should do the 3D ultrasound of these patients. So absent uterus, I have already explained it in the initial study that this is the bladder, and beneath the bladder, it's a transabdominal scan. We are not able to see the uterine tissue. Both the ovaries are normal. So it was a case of Mayer-Rokitansky-Kuster-Hauser syndrome. The ovaries will be normal. The lower third of the vagina will be there, and there will not be any uterus. So we have to create the functioning vagina, and for the fertility management, gestational surrogacy needs to be done, or a uterine transplantation. So now I hope it is clear to everyone, the septate uterus, the bicornuate, and the unicornuate uterus. Now, many times the question arises whether we should go for an MRI or we should go for a 3D ultrasound to diagnose these uterine malformations. I would say that 3D ultrasound is a very good modality, and it has similar sensitivity to the MRI. As we can see here, that the sensitivity of MRI and 3D ultrasound is comparable, and the specificity, and ultrasound being easily available, the cost-friendly, time-friendly, it takes almost 20-25 minutes to do an MR, as opposed to just 2-3 minutes to do an ultrasound. So ultrasound scores over MRI for these congenital uterine malformations, the 3D ultrasound. If we have any confusion on the 3D ultrasound, then definitely we can proceed to the MRI, but MRI should not be the first choice to diagnose a 3D uterine malformation. First, we should go with the ultrasound. So just to summarize the things which I have covered, first we should, whenever we are doing ultrasound, see whether the uterus size is normal or not. If the uterus size is small or the uterus is absent, then we have to think of Mullerian agenesis or uterine hypoplasia or a unicornuate uterus. If the uterine size is normal and we are able to see the 2 endometrial canal, then we need to look at the external fundal indentation. So if the external fundal indentation is more than 1 centimeter, then it is or the distance between the interosteal line and the external fundal indentation is less than 5 mm, it is a bicornuate uterus. If the external fundal indentation is less than 1 centimeter, then we go ahead and look at the internal fundal indentation. Again, if the internal fundal indentation is less than 1 centimeter, it is an arcuate uterus. If the internal fundal indentation is more than 1 centimeter or more than 1.5 centimeter by some committee, it is a case of septate uterus. And if it is a normal triangular shaped cavity, it is a normal uterus. Hopefully the things are clear. Thank you for patient listening, ma'am.
Isha, thank you, Dr. Isha. It was a wonderful talk. I would request our chairpersons, Dr. Niharika.
Yes, Dr. Isha, it was wonderful presentation. You covered each and everything, and you just covered that ratio which we take from the myometrium to the fundal indentation to the serosa, and you have to take the ratio. That is actually the new thing we have known. This has not been, I think, mentioned in any of the classification, that you have to take the ratio between the two, and if it is more than 50%, then more of diagnosis goes in favor of septate. And yeah, it is a new thing that we have learned today. Otherwise, everything fundal indentation and everything angle is given, but the ratio you have given, it is good, very good, and you covered each and every classification. But I just want to know what is the current. See, if I send some patient to diagnose any Mullerian anomaly, so what is the current classification you follow, whether it is ASHRAE or whether it is American Association? What is the current which you are following?
Ma'am, different gynecologists follow different guidelines actually. So
Yeah,
here in our area, the ASHRAE classification is more commonly.
ASHRAE. Yeah, but I think the ASHRAE is little bit cumbersome to mention, because they have diagnosed with vagina and cervix, but currently you are doing it with ASHRAE only. Okay. Okay. And secondly, I want to know if in nulliparous patient, in unmarried female, if the patient comes with pain and we want to diagnose, so what is and to rule out any vaginal septum, we can't do PS, we can't do internal examination. So how can we diagnose in this? So in that case, we have to go for MRI, or it can be diagnosed by 3D scan only?
MRI will be
MR.
better.
I think it will be good if we do MR in such cases. Okay.
Because will not get that much resolution to see.
Okay. And in your current practice, what percentage, what is the most common modality? I know septum is one of the most common, but apart from septum, which is the second most common, I must say, Mullerian anomaly you are seeing in your practice now? Because in books it's been written that biconate is usually 10%. But let me just, I have seen in my 15 years career, I have seen just one case of biconate. And my teachers, or they have said that it's always an always septum. You don't just diagnose, and biconate is very, very rare. So I want to know whether you see biconate also. It's like more of an everything, every time it's a septate only.
Oh, ma'am, we have seen bicornuate uterus also, and we have seen bicornuate with pregnancies also.
Okay, so they go obstetrically well, or no.
I saw one case a few days back. I did not knew the history that it is a bicornuate uterus, but I was able to see that there was a pregnancy. Able to see, some soft tissue, the uterine myometrial like structure near the cervix. So
okay.
I got confused, not knowing that it is a bicornuate uterus, that it is some fibroid or some thickened myometrium. Then I went back to the patient, asked for her previous pregnancy records. So had undergone a cesarean section. So in that, it was mentioned that it is a bicornuate uterus. And then on the second look ultrasound, when I looked at it more carefully, it turned out that the tissue which I was able to see near the lower uterine segment, that was not like a fibroid or some myometrial tissue. It was the second horn of the uterus. So I've seen two bicornuate uterus with pregnancies also, ma'am. Apart from, I've seen like almost 10, 12 bicornuate uterus I've seen in my career. Data are definitely common, but bicornuate uterus are also very common. Unicornuate uterus are also very common.
But then how can you diagnose if any unicornate uterus is there and you do the 3D scan? Obviously, you will see single cavity banana shape. But if there is any rudimentary horn present with or without communication or functional endometrium, can you diagnose on the 3D scan also? You have to go for MRI in that cases. I just want to know.
The ultrasound, we can see if it is near to the uterus, then we are definitely able to see on the 2D scan. If it is if it is non-communicating or far from the main uterus, then it is difficult on 2D scan because we do not look at the relatively.
Yeah. So I think in that case, MRI will be better option.
No,
rather
can I
to
add?
go for- yeah. Yes, ma'am.
Can I
Near to
add?
the communicating, then we are able to see very good on ultrasound.
Yeah, okay.
Yes.
Can I add?
Yes, ma'am. Yes,
Okay,
Dr.
so-
Ladbans, ma'am.
Yeah. So very important, one thing we all need to know is unicornuate or bicornuate or septate all needs to be handled on a 2D scan, first of all, right? You can actually diagnose all these anomalies on 2D scan by just making sure whenever you're doing a scan, right, you are supposed to make sure that you do a scan in sagittal and transverse. Once you do transverse, you are going to definitely see what do you call the two cornua, right? Am I right? Am I audible?
Yes, ma'am.
Yeah. So you'll be able to see two cornua, right? Two cornua. The moment you go up towards the fundus, you will see two cornua, right? You're sorted out there. And if you see one cornua, it's a unicornuate uterus. You don't need to see the shape of whether the shape is banana shaped or not, right? That's very important. Second, I would like to add, whenever you have an unmarried girl or a girl who is sexually not active and you suspect an anomaly, a Mullerian anomaly, please do a transrectal examination. Call her mother, counsel her, and do a transrectal examination. We have done it so many times, not only for this particular indication, but for many indications otherwise, right? Your life becomes easy. You are actually in the rectum and you can handle the probe very nicely. So that's how I do it. So I thought I'd like to share, whenever you have a problem as far as vaginal septum is concerned, yes, you may not be able to go ahead with that part, but at least you will be able to see the anomaly very well. And it's very well seen, let me tell you.
Ma'am, suppose the girl doesn't allow transrectal. Is
Counsel-
it perennial approach okay?
No, you cannot.
No.
You
Okay.
cannot. You need the fundus.
Okay.
Your answer lies in the fundus, right?
Okay.
So, I mean, you just have to counsel. We have done, girls as young as 13, 14, right? So just
Right.
have to counsel. Call her mother, make things comfortable, and everything can happen. Yeah.
Sure.
Yeah.
Thank you.
Ask one question.
No,
Hello.
Yes.
Hello, ma'am. Any kind of bowel preparation prior to the rectal, transrectal ultrasound
Namaste.
in young
You
girls?
don't. No, you don't need it.
Mm-hmm.
You don't need it.
Okay.
Yeah. If any more questions, any more comments from our chairpersons? Otherwise, we move to the third talk then. Dr. Preeti and Dr. Niharika, Dr. Deepika, anybody there? I think Dr. Rakhi had not joined. She has sent her apologies. Right. So I
I would
think
like to say one thing, ma'am, that in addition to this imaging, we need to look into the history also. Sometimes what appears banana shaped on 3D ultrasound, it turns out to be turns out to be like Asherman's. The half cavity is obliterated, and on 3D ultrasound it appears to be a unicornuate. But sometimes like we need to look into the history also.
Is very
Like we
important.
have seen cases that it appeared unicornuate, but actually turned out to be an Asherman syndrome.
yes.
Thank you, Dr. Isha. It was such a wonderful presentation.
Thank you, ma'am.
So thank you so much, Dr. Isha. You taught us like students with taking care, teaching like as if you're teaching on a board. And we really felt, I mean, the concept has been more clear. Now, once again, when we go through and we read it and we do it practically again, we will recall all these practical tips that you have given, and also what Dr. Ladbans ma'am has added. So thank you so much. Thank you. Yeah, we go on to the next session, Dr. Lakshmi.
Yes, let's move on to our next session. So I would like to invite our chairpersons, Dr. Ratika Jindal, Dr. Sakshi Bansal, Dr. Suman Marsh, and Dr. Shubha Chopra. Yes, so we have a very eminent speaker, Dr. Kuldeep Singh. Sir will be speaking on color Doppler in infertility. Everybody knows Sir. Sir is a master trainer in his field of ultrasound, which he is so passionate about. He practices ultrasound in Delhi and is known for his skills in ultrasound in OBGY and infertility. He has authored 16 books on ultrasound in OBGY and infertility. His books have been translated into Spanish, Chinese, and Portuguese. He was awarded the Imaging Science Award in the AICOG in Delhi. He is successfully running Sono School, which organizes various training programs in ultrasound in obs-gynae and infertility. He's going to be launching his latest venture, VQAUAL, that is very we question, you answer and learn, which is going to cater to basic and advanced academic programs. We are fortunate to have Sir with us today, and we are eager to listen to him. Over to you, Sir.
Thank you. Thank you so much. Thank you, Dr. Jyoti, Dr. Meenu, Dr. Manju, Dr. Lakshmi, for giving me this opportunity. I hope I'm loud and clear and everybody can hear me.
Sure,
Yes,
sir.
sir. Yes, sir.
So since this is another a very important talk that we sir is going to talk on the color Doppler in infertility. So it is actually color Doppler is a very integral part to all of us infertility specialists as such, because wherever whether we are doing a follicular monitoring or we are seeing the endometrium, everywhere once we have done once we have done our basic measurements and the follicle measurements or the endometrial measurement, then always it has to be a habit to put in the switch on the color Doppler so that we can understand whether this follicle is about to rupture, if it is whether we should what is the right time to give trigger, and should we wait, should we hold on to the trigger if that follicle has not matured as yet, though the follicle size is around 17 18, where we are still in a dilemma what to do. And also then about the endometrial blood flows, which are very very important, that we need to see on a Doppler, whether it is it goes in grade 1, 2, 3 or 4. So if it is 3 and 4, we are happy. If it is still 1, 2, maybe we might have to increase the dose of estrogen, or we might have to give more maybe add more agents which can increase the blood flow. Let's say we may have to even maybe sometimes cancel that particular cycle if the flows are not that good. So I think that way color Doppler is something we should all be very very knowledgeable about, and we should not think twice before putting the color in whatever we are doing, so that the more we do, the better we experience we become. And in the meantime, if Dr. Isha or Dr. Ladban, since sir I think maybe joining again, I can't see Dr. Kuldeep sir. So maybe he must have logged out and must be joining. So if you can give us some practical important tips for our practice, anybody out of you, if you could share some tips and tricks till the time Dr. Kuldeep sir joins.
Okay. Right. If you have, I mean, like as far as follicular monitoring is concerned, you highlighted the importance of vascularity. It has to be functional. You can't have morphology only. You need to add the hemodynamic assessment. So that's how you can, actually monitor your dosage, one part. And of course, as far as the settings of the Doppler is concerned, that is very, very crucial. Make sure you call the application specialist and get it done for your endometrium and as far as for the ovaries is concerned, because that is how it's very crucial. And also you have to understand that whenever you have a uterus, which is perpendicular to the beam, that may be sometimes restrict the amount of vascularity which you see. And also sometimes you must wait whenever you switch on your color Doppler, and if something is not coming, try to wait, because there could be a uterine contraction which will momentarily reduce the flow or even show complete absence of the flow. So that is the time when, and secondly, I am a very high propagator of power Doppler. It's very, very important because power Doppler adds to the small, today we have slow flow technique, right? And we can do a slow flow technique and map up the vessels right up to the spiral arteries, right from the entire arcuate vasculature. The uterine vasculature, starting from the arcuate to radial to spiral arteries, can be mapped very nicely, right? So one, take care of your optimization. Two, use power Doppler. Make sure your PRF is, if you're using GE machine, your PRF is 0.3 to 0.6. If it is more, please optimize your color Doppler. You should know how to reduce the color gain, increase the PRF to make it look optimum, right? Anything which is less or more can make an erroneous diagnosis. So whether you're looking at a solid lesion, you need to know that, the vascularity. A solid lesion will be always called a solid, it will show vascularity. That's how you will differentiate from other things like blood, which will be avascular. So I feel optimization, power Doppler are the two most important things, whether you're looking at a uterus, you're looking at what do you call an ovary, ovarian lesions, whether you're looking at the follicular study. I always do a follicular study. Normally people do follicular study, just, they do endometrium kitna hai, follicle kitna hai, and then they just give the reports. That's not the way to do it. You have to add the perifollicular flow. How much is the, what is the first dominant follicle? How much is the perifollicular flow? How much is it, whether it's 1/3, half, 75%? So you have to grade the degree of the circumferential flow of the follicle. Two, you have to tell them that how is your flow into the endometrium looking at? Are you looking at, as Dr. Jyoti very accurately pointed out, zone 1, 2, and 3, 4. 3, 4 are good for conception. You have to tell them what is the uterine PI. You have to tell them how much is the endometrial RI and PI. And also these are the various things which are very, very crucial. So I think I've taken enough time. I think Dr. Kuldeep is there for his talk.
Thank you so much, ma'am. Thank you. Thank you for your practical tips. Actually, in between, I think he had logged out and he could not log in again. So, and thankfully now that he has logged in and we can also see your screen.
Perfect. I'm so glad. Sorry, apologies for the trouble. I think so my computer's become a little too heavy with all those videos.
No, but we would like, आप कह रहे थे ना कि नहीं, let's take this talk next time. I was praying that you log in and we
Very.
listen to you today evening only. So
Perfect.
without wasting time, we go to you, sir.
Thanks so much, Jyoti. Thank you. And I'm going to be talking now on the color Doppler in female infertility. What you always need to remember when you're doing a color Doppler, it always has to be a transvaginal scan. But again, a word of caution, the first time the patient comes to you, it always should be a transabdominal scan as well. A report looks very poor, that uterus fine, right ovary fine, left ovary not seen. Now, what does not seen mean? And when you're doing it, or because if an ovary is high up, you could be missing out on a transvaginal because the resolution is better, the frequency is better, but the depth is not that great. What all do you need with it is 2D, which is the basic. Always start with the basic. Don't jump on to doing straight away 3D. Don't jump on to straight away doing a color. First, get your orientation, get your eyeballing correct on a 2D, then start off with your color flow mapping. That's basically what you're looking at, red and blue. which basically means flow towards or away from the transducer. Use your power angios, especially in infertility practice. Whichever vessel you need to insunate, do a spectral Doppler, and whenever required, you can do a 3D as well. The flow of my talk is going to be, first we're going to be talking about a little bit about etiology. Then where do you need it in a baseline scan, in follicular monitoring, and in the luteal phase. In the etiology, you would be needing a color Doppler or a color flow map for looking at polyp. And when I say color flow map, means you're including your power angio as well. You need to be looking at the fibroid. You need to be looking in for, am I seeing endometritis or not? Then on a baseline scan, you need to be looking at uterine flow and ovarian stromal flow. Coming on to the follicular monitoring, you're looking at endometrial flow, the uterine artery flow, the peak systolic velocity in the follicle, and the perifollicular vascularization. I hope my slides are moving and I'm audible.
Yes, sir.
Perfect, Ji. And in the luteal phase, you're trying to look in for corpus luteum and the corpus luteal flow as well. So we'll go step by step and see what exactly has to be done. Any questions, you can always put that up on the question column. First thing that you're looking up is a myoma, looking at subserosal, intramural, or submucosal. And for infertility, as Dr. Ladbans has nicely demonstrated, you're looking in for submucosal fibroids, and you need to be watchful. They're well defined. That's how you're going to be differentiating it from an adenomyoma. They're usually hyperechoic, can be hyperechoic, can be showing degeneration, a mixed echo pattern, or it can show calcification. Usually rounded, and they show peripheral vascularity. If you're looking at vascularity, it's normally circumferential. If you're looking at a flow through any of these lesions, that's usually an adenomyoma. But if you're looking at circumferential plus an intralesional flow, you should be careful that you're looking at a degenerated fibroid. There you're looking at a fibroid over there. You're looking at a circumferential vascularity. You're looking at flow going intralesional as well. So you need to be careful. Don't label such a large one. If you go 2 to 5 as you're looking at an adenomyoma, this is a degenerated fibroid. Sorry, I'm again asking, is the video running? Because that's the first video we started with.
Yes, sir. Yes.
Perfectly. Thank you. You're looking at circumferential flow. Look how well circumscribed it is. You could be looking at calcification, rim calcification, multiple punctate foci. Fibroid is going to show you discrete margins. Adenomyoma is going to show you ill-defined margins. The surrounding myometrium could be normal. In an adenomyoma, you're going to be looking at all the features, a speckled echo pattern, the salt and pepper appearance, enlarged globular, bossulated uterus, usually the posterior myometrium thicker than the anterior myometrium. You could be looking at myometrial cysts, so just be careful on those. You're looking at well-defined rim with few vessels entering the mass. In this, the color Doppler architecture, or when you're using a power angio, is going to be unremarkable. Coming on to the polyp, you're looking at this. The moment you're looking at an echogenic rounded area, you're going to first think of that it's a polyp. The moment you're looking at the cavity being lifted up, or you're looking at a single pedicle artery sign, that means you're looking at a polyp, endometrial polyp. You're looking at this cavity. That's the anterior endometrium, posterior, and bang in the center, and you're looking at an endometrial polyp. Endometrial polyp. Looking at vessels over there, looking at multiple polyps over there, multi-slice view. Again, various software things about Ono 3D that you can figure out. You're looking at an endometrial polyp. The pedicle artery sign, the single feeding vessel, can be seen extending to the polyp on color Doppler. The vascular pedicle, 76% sensitive, 95% specific for endometrial polyps. That's the polyp you're looking at. That's the vessel that you're seeing coming from the anterior portion. Doing a 3D over there. That's what you're looking at. This is the camera aperture. Whatever is going to be drawn over here, you're going to be able to see it over there. That's the endometrial polyp. And basically, when you take a stripe, you keep your transducer, you hold on to your transducer, and then play with the images. That's a 3D. But while scanning, if you're doing it, this is what I'm doing. This is a 4D scan or a live 3D. The endometrial polyp seen over there, and you're looking at the vessel coming inside. The moment you're going to be looking at a fibroid, it's not going to be echogenic. It's going to be hyperechoic, and you're going to be finding multiple vessels around the periphery. Endometrial polyp. See how you're looking at the cavity curving over there. That's pathognomic of an endometrial polyp. And you're looking at the vessel coming inside. It's not that in all cases you'd be needing a 3D, though I normally do a 3D for all the cases because now with practice it takes a minute. But a color Doppler definitely essential now. Looking at endometritis and what are the features you're going to be looking at. Thick, echogenic, there could be a fluid collection, moderately vascular when I'm looking at acute endometritis. Echogenic, fluid inside, plenty of vascularity. I'm looking at endometritis. Looking in for synecdoche. There, you're looking at over here. The moment you are looking at a irregularly thickened endometrium, it was thick, then thin, again thick, because it normally has to be a teardrop appearance. But if it's thick, thin, again thick, then again thin, means you're looking at a adhesion. That's the first sign on a 2D. You're going to be looking at on a 3D, and on color Doppler, you're not going to be looking at that greater vascularity. Again, the pathologies that are there for looking for adhesions and why do they cause infertility, making the uterus inhospitable, interfering with the sperm transfers, and trouble over there. This is pathognomic of a tubercular endometritis. You're looking at the beak sign or the claw sign towards the end over here. That's the cavity over there. You're looking at the endometrium, and the moment you see this, you're sure of that you're looking at tubercular. Again, I repeat, you can never be giving a histopathological diagnosis on an ultrasound. Remember that. But you can always say suggestive of, and then it has to be. This is again when you're looking at in the junctional zone, punctate foci of calcification, pathognomic of that it could be tubercular. That's an adhesion that you're looking at, a band that's going through and through. You're looking at endometrium, that's a longitudinal scan, the sagittal scan. You're looking at endometrium, you're looking at a band which is similar to the myometrium, and then again you're looking at, that's a band traversing through and through. And you're looking at fibroids as well, mostly subserous in this case. Now comes on to when we're looking at a baseline scan. That's exactly where you need, because whenever I've been going to conferences, they say we're just looking at the antral follicle count and that's it. No, you need to be looking at not only an ovary which is normal ovary or a low reserve ovary. You need to figure out on a color Doppler whether it's a poorly responding ovary on whether we're looking at polycystic ovaries. In a pre-ovulatory scan, mid-cycle, we're looking at endometrial receptivity, follicular maturity, the timing of the HCG. When is the trigger to be given? When is the embryo transfer if one is doing an IVF to be done? And in the luteal phase to look in for corpus luteal vascularity. So these are the 4 things which we're going to be looking at on a baseline scan. When you're doing a color Doppler, why are we doing it? Because the ovaries are silent. Estrogen and progesterone and all the hormones are at the lowest. No endometrial flow should be seen. And in the uterine artery, when you're looking at subendometrial flow is going to be present, means there are high basal estrogen or progesterone levels. High estrogen would be if there's an early recruitment of the follicle or you're looking at PCOS. Otherwise, normally you should not be looking at flow. High progesterone if you're looking at a residual active corpus luteum from the previous cycle. And the spectral Doppler, which we normally do it in the mid-cycle, but you can just have a peep when you're doing your baseline scan as well. The uterine artery resistive index, if it's more than 0.79, it indicates high doses of stimulation would be required for endometrial maturation. So you need to be careful on this. All the 3 indices, SD ratio, resistive index, PI or the pulsatility index, they all mean resistance to flow. So if the resistance is high, means the blood flow is less. That's very important to understand the basic. Then whether you're using an RI or a PI, immaterial, whichever book you're using, whichever charts you're following. But nowadays, for all the indices, we normally are using the pulsatility index. I'm looking at a high flow, high resistive index over there. If I'm looking at a high estrogen level, normally I should be looking at a thin linear endometrium if there's an adequate downregulation. That means the basal estrogen level is low. That's how you're going to be looking at a thin endometrium. If the endometrial thickness is more than 4 millimeters, inadequate downregulation. You're going to be looking at a thick endometrium, indicating you're looking at high estrogen because of multiple follicles of PCOS or an early recruitment of the follicle. You can both see by the ultrasound. I'm looking at a follicle which has developed so early. It's an early recruitment, so the values are going to be increasing. Depending on first the androgen levels go up, then the estrogen FSH, and that's when the negative feedback mechanism is going to come. If I'm looking at a thick echogenic endometrium on a baseline scan, that could be because of a progesterone increased levels, because of a corpus luteum from the previous cycle. Increased flow in the endometrium. So I'm not comfortable with this flow on a baseline scan done at day 2, day 3. I'm looking at a corpus luteum, almost a ring of fire sign over there. On a baseline scan, you're supposed to be looking at the ovary as well. You're assessing the ovarian diameters, assessing the ovarian volume. You're assessing and counting the antral follicles and the stromal density. A color Doppler or the power Doppler box. You need to be careful. Do not make a huge box because there's going to be plenty of noise. These are the settings that you're going to be doing. The PRF has to be set at 0.3. Now, there are few machines which can get your PRF at 0.3, but otherwise use the lowest PRF. PRF is pulse, repetition, frequency, and that's directly proportional to the scale or the velocity. So reduce, some machines are going to give you a scale, some machines are going to give you PRF, some are going to give you both the things. The wall filters have to be at the lowest, optimum gains and balance settings need to be done. That's a color box. Don't use a huge color box, just on the ovary, and you're supposed to be looking at the vessels in the stroma. Do not see them closer to the antral follicles. If you're looking at vascularity, you need to be insonating the vessel and looking in for intra-ovarian resistive index, peak systolic velocity, and interrogate or insonate the vessel that shows you brightest color. It's a very long topic, so that's why I've cut short the slide so that we can finish it. Looking at stromal flow. And these are going to be vessels which are going to be very small. So be careful. If you're not able to get them, just try a little harder. Use your power angios. Because in infertility practice, except the uterine artery, you're supposed to be looking at on a power angio. So the ovaries are going to be categorized into a normal ovary, a low reserve, a poorly responding, or a PCOS, and that's going to decide what stimulation protocol are you going to be using, whether you need any additional supportive therapy. These are the features of normal ovaries. If you're just doing a 2D, you're going to be figuring out the largest diameter 2 to 3. Ovarian volume, I normally take 3 to 10 ml. A follicular number per ovary of around 5 to 12. Isoechoic stroma, stromal resistive index of 0.6 to 0.7, stromal peak systolic velocity 5 to 10 centimeters per second. These two are going to be seen on color Doppler. They're going to respond to standard stimulation protocols, and they're going to be producing adequate follicles for the concerned ART. I'm going to be looking at stromal flow, and I'm going to be figuring out whether I'm looking at a good peak systolic velocity, whether I'm looking at a good resistive index. What are low reserve ovaries? I'm going to be looking at antral follicles less than 5. The ovary is going to be small. It's going to appear as a partially atrophic ovary. The volume is going to be less than 3 cc. If you're looking at undetectable basal ovarian stromal blood flow in one ovary, that's going to be related to low ovarian reserve. Barely any antral follicles seen over there. Then comes on to poorly responding ovary. Now, if you've done a pituitary suppression and you're trying to figure out the ovarian responsiveness, you're going to figure out that both the ovaries look the same, but in this, I need to be giving much more injectables, much more medication. The other ovary is responding quite fast. This is the reason. And this is because you've used your color Doppler judiciously. The resistive index in a normal ovary should be between 0.6 to 0.7. In this, it's higher. So if the resistance is higher, blood flow is less, you're going to be using much more of the medication than otherwise would be used. Peak systolic velocity should be between 5 to 10 centimeters per second. In a normal ovary, in this, it's less than 5. Boulogne criteria, you're looking at advanced maternal age, a previous poor ovarian response, abnormal ovarian response, looking at antral follicle counts, AMH. If you look at the Poseidon criteria, we're looking at low prognosis patients. If you see 1, 2, 3, and 4, which you're all much more well aware of, you're looking at less than 35 years. Again, the optimum response or a suboptimal response when you're looking at problems with the AFC, with the blood flow, is when it's going to be trouble, especially more for the Poseidon group 4. Looking at a PCOS over there, you're looking at much more of the stromal component. You're looking at much more of the cystic component. And you're going to be figuring out that nowadays you see many lean PCOs. That's because of this only. The cystic component is much higher. You're looking at vascularity over there. There's plenty of stromal hyperemia. You can do a 3D and looking for, you can do a sono AVC, you can do a 5D follicle, whichever you're doing, and you can count them. Various classifications. If you're looking at an ovarian volume more than 10 ml, you're looking at PCO. Again, we were looking at more than 12 antral follicles. Now we've gradually increased that, we're looking at more than 16, more than 20. New guidelines say more than 26. But for the sake of uniformity, they say the moment you're looking at more than 20 is when you're suspecting and thinking of polycystic and looking for the biochemistry as well. You're going to be looking at number of antral follicles, arrangement of antral follicles, and the stromal predominance. All the atretic follicles falling into the stroma and increasing the stromal quantity. Various features of a PCO, not necessarily that all features are going to be seen. Diameter more than 3.5. I normally take an ovarian volume more than 10. This more than 20. The stroma is going to be hyperechoic. Intraovarian flow is present. I'm looking at a stromal resistive index, which is going to be less. The peak systolic velocity is going to be high. This is opposite to a poor responding because these are hyper responders. That is why we get the hyperstimulation in such ones. The PI in the uterine artery on a baseline scan is going to be high. The endometrium is going to be atypical. These are on 3D. Multiple antral follicles, plenty of cystic areas. And I'm looking at plenty of stromal hyperemia. This is when you're looking at a 2D picture and you're looking at color as well. Much more useful when we're looking at fetal hearts. So you're going to be on a baseline scan dividing them into normal response, poor response, and a hyper response, or a normal reserve, low reserve, and a high reserve or PCOS. Coming on to the follicular maturation, we know the follicles grow at a rate of 2 to 3 millimeters. And when you're looking at an 18 to 20 millimeter follicle, it usually contains a mature oocyte. You're looking at uterine and ovarian cyclical changes on 2D, and you're looking at the vascular phenomenon. Famous chart which we all follow to see this is at a quiescent level and gradually things start increasing. Day 1 to day 5, on a baseline scan, the thickness has to be less than 4 millimeters, and you're not including the fluid over here. It has to be anterior plus posterior. Early follicular phase, the thickness is between 7 to 9, and you're looking at a triple layered pattern. Gradually, the junctional zone is going to fizz away when you're looking at a late follicular phase. This is just mixing or dissolving in the myometrium. That is when you're looking at a pre or a periovulatory endometrium, and the thickness is around 9 to 12 millimeters at ovulation. And you'll find something over here in the left ovary corresponding over here. You're looking at a cumulus over there as well, a nice thick juicy endometrium, which we are all comfortable about in the mid-cycle, and you're looking at a nice follicle with a cumulus at the 9 o'clock position. The B-mode features of endometrium. Between 8 to 10, optimum, but even up to 7 we are comfortable with. But we need to be looking at a multi-layered or a triple-layered endometrium. Any breach or irregularity, be careful. Why is this happening? Luteal phase, you're supposed to be looking at a thick echogenic endometrium. You're trying to figure out about endometrial pathologies, mid-cycle is always the best. If it's an echogenic endometrium, you're going to be missing out on an echogenic endometrial polyp. If you're doing it at day 1 to day 5, you're going to be missing out on an endometrial polyp because the endometrium is quite thin. That's why when you're doing a follicular maturation, you're going to realize that by 8 or the 10th day, you start looking at a polyp which you weren't able to see earlier. For ovarian pathologies, day 2, day 3 is the best. When you're looking in for Doppler in the uterus, you're supposed to be looking at proliferation of spiral arteries, subsequent endometrial invasion, and a reduction of impedance to the main uterine artery. Various zones, 1, 2, 3, and 4, and I'll show that to you. The moment it's subendometrial or in the junctional zone, it's zone 1. This is outer zone. This is mid-zone, and when it reaches the cavity, the vessels reach the cavity, that is zone 4. That's how you're supposed to be explaining whenever the embryo transfer has to be done, whether is it the right time or not. Looking at vessels, endometrium is good, but it's not necessary it's going to be good on color. So if the perfusion is not good, we're not going to get a good response. Much better to hold on for a day or two and then again check that. We're looking at a zone 2 vascularization, almost going to zone 3. Zone 2 vascularization is a must. Uterine artery Dopplers. You need to be insonating the uterine artery and the PI should be less than 3. Anything between 2 and 3 on the day of transfer or on the day of HCG is ideal. Notching, you don't need to be worried because the notching is going to be there. You're supposed to be looking at the pulsatility index. There should be enough diastolic flow. And when you measure that, you know you're doing a good job in terms of looking at a PI of less than 3, both sides. The PI is quite higher. The successful implantation of the embryo in the uterus depends on the ovum quality and the receptivity of the uterine endometrium. So you need to be watchful that the receptivity of the uterine endometrium has to be good. So you're looking at endometrial perfusion and uterine artery flow. If the flow is adequate, it means good endometrial growth and receptivity. If you're looking at increased impedance to the uterine artery, the endometrium is not going to grow that well. From the uterus onto the follicles or the ovulation monitoring. The endometrial things are going to be fresh for this cycle. The follicles are going to start off from the previous cycle. So that's when we need to be having the phenomenon of selection, dominance, and maturation. This cycle, all this has started off in the last cycle. When you're looking at an increasing perifollicular blood flow, lowering resistance, it correlates well with the rising estrogen levels. And when there's a rising perifollicular peak systolic velocity, meaning the LH surge is on. The B mode features. You're looking at a follicle which is 16 to 18 millimeters, has thin walls, regular round shape, no echogenicity in the lumen, and shows a thin hypoechoic rim surrounding the follicle. 35 to 40% of the times, you are going to be looking at a cumulus as well. That's what we follow in Sono School as well. The eyes are going to see what the mind knows. So if you're aware of it, you're going to try and see it. You'll be able to. And the second dictum we follow is, if anyone can do it, you surely can do it. When you're measuring the follicles, if it's a rounded one, measure only one dimension. If it's an oval shape, measure 2 dimensions and take a mean of them. Now for Doppler, when you're looking at, again, the PRF settings has to be at the lowest. Bring down your scale knob to the lowest. Turn it anti-clockwise. Or if you have a PRF knob over there, reduce it. The wall filters have to be at the lowest so that the lowest velocity vessel, which is going to be there, you can see it. And as I repeated earlier also, a power angio has to be done. You need to remember the perifollicular vessels are the ones that are going to obliterate the follicular wall. If they're not obliterating, they are not the perifollicular vessel. There's no point looking at them and claiming we're looking at a good follicle. Again, 1, 2, 3, and 4, and this is the percentage of the circumference that's taken care of. And if you're looking at a better perfusion, means good quality oocytes. So up to 25, 25 to 50, 50 to 75 or more. Around 50% is a good perifollicular vascularization. This is not a perifollicular vessel. This is not. Only the ones that are obliterating the follicular wall are good perifollicular vessels. We're looking at a good follicle over there. Good vascularity over there. various modes on the color Doppler, where you can really look, and even more than power angio, you can see for the slightest of flows. Perifollicular flow. You could be looking at a big follicle, but if it's not showing you good flow, it's not going to be a nice one. On the 3D, you're looking at a good perifollicular flow. This is going to be the future, where you're going to be figuring out a follicle and it's going to show you the amount. Might be you say it's grade 1, I would say it's grade 2. So this is going to quantify. It's going to be an objective evaluation. What happens when you're looking at, there's going to be a fall in the perifollicular resistive index starting 2 days before the ovulation. It reaches a plateau, remains low, then with gradually rise, it reaches up to 0.5 in the mid-luteal phase. So you're going to be having a resistive index here. It's going to go down, remain low, and in the mid-luteal it again comes up, because all the action is when it's on the lower side. You're going to be looking at a resistive index of 0.4 to 0.48, and the peak systolic velocity should be more than 10 centimeters per second. You're looking at a good flow, peak systolic velocity. When you're doing or taking a power angio, you're not concerned or worried about angle correction, so you're comfortable. The ovarian flow correlates in determining the most appropriate time to administer HCG to optimize the recovery rate. You're looking at more than 10 centimeters per second. Now, what are the predictors? If you're looking at a cumulus, means within 36 hours. You're looking at decreased reflectivity around the follicle, a double contour sign, within 24 hours. You're looking at a crenation of the follicle within 6 to 8 hours. There, see over there. One could see the follicular, the echoes coming over there. So that's almost the follicle is about to rupture. You're looking at a double contour sign. The two walls of the follicle and the fluid is going to keep on accumulating, increase the pressure in the follicle so that pop comes out the oocyte. Plenty of perifollicular flow. The predictors of ovulation: disappearance of the follicle, fluid in the pouch of Douglas, and development of intrafollicular hole, what we call as the corpus hemorrhagicum. Fluid over there. But be careful, changes have happened there. How much was the fluid otherwise a day before? If it's increased, that's when you're going to be thinking of a follicular rupture. Looking at a corpus luteum over there. Looking at plenty of vascularity around it. And when you insunate the vessel, you're going to be looking at low impedance flow. Less than 0.55 resistive index, we are comfortable about it. So to summarize, last slide, if you're looking at in the follicle, in the endometrium, the follicle size, after 18 millimeters, if it's a medicated cycle, we give a trigger. If you look at injectables, they've started giving the trigger around 16 to 17 millimeter follicular size. Endometrium, 8 to 10 millimeters, should be multilayered. Morphology, it has to be thin wall with no internal echoes. Vascularity, if I'm looking at around grade 2, 50 to 75%, it's basically grade 3, but grade 2 around 50% is comfortable. If you're looking at grade 2, zone 2 is fine. Up to zone 3 or zone 4, voila, you're definitely going to be quite successful. Resistive index between 0.4 to 0.48, endometrial vascularity less than 0.5. I normally routinely don't do this, but whenever required, and that's what the book says, you can always do that. A peak systolic velocity has to be more than 10 centimeters per second. Uterine artery pulsatility index, I follow less than 3.0. Some books say less than 3.2. These are the things that you're going to be doing on a 3D. Volume of the follicle 3 to 7, of the endometrium 3 to 7. You should be able to see a cumulus on a 3D. The endometrial myometrial junction has to be intact. Power Doppler, more symmetrical, higher the better. So once you start off with, and there's this common question, when should you call the patient if they've come to you for the first time for a scan? Do it there and then, because you'll realize it. If there's any other problem that you need to be figuring out, otherwise calling them next cycle for a baseline scan sometimes could be a waste of time if you figure out there's a large endometrioma there. So the patient comes to you for the first time, do a scan. If you're looking at something in the endometrium, you're looking at a fibroid, you're looking at some other problem, switch on your color instantly. There is no hassle, and once you get into a practice, you'll be able to. Then, whenever you're calling them for a baseline scan, try and figure out how's the endometrium, how is the ovary, whether normal, low reserve, poor responder, or a PCOS. Try and looking for color Doppler is not to be done on an 8 or a 10 millimeter follicle. The moment they cross 12, or most likely when I do it is when they're more than 14 or 15 millimeters, start doing your color Dopplers for the follicles. You can keep on doing the 2D before that. And then gradually as they approach to 18 millimeters, try and see when is the right time to give a trigger, looking for the endometrial vascularity. Whether you're doing it for an IVF or for an IUI or for a timed intercourse, it's always better to do a good job. When you have your machine to help you out, use it judiciously so that you give a good result to the patient. Thank you. Thank you so much.
Thank you, sir.
Yeah, Dr. Lakshmi.
Thank you, sir, for such an elaborate and such an informative talk. I think we now have a lot to learn. We have learned a lot about color Doppler in infertility. So especially the perifollicular, the one you show, the 3D. It was really a very a new thing that we saw. The 3D perifollicular blood flow.
In fact, the same thing comes on for the endometrium as well. But
Right,
again, there was lack of time, so I didn't want to. Otherwise, this was like 220 slides, and I put them into like 100 slides.
Sir, I want to ask how to calculate RI and peak systolic velocity of the follicle. Where to focus?
See, whenever you're looking at a follicle, the one that's obliterating the follicular wall, take that. Normally, take it at around the 2 o'clock position or the 10 o'clock position. That vessel is going to be always the ideal one, and you're going to be getting a good flow.
The major vessel we have to locate.
Absolutely. The one that is obliterating the follicular wall, not adjacent to it. And if you're finding something which is like 40 centimeters per second or 50, that means it's not the vessel of the follicular one. This is something adjacent that one has done it.
And then we have to put the power Doppler on that vessel in the color window.
Basically, first we're going to be switching on color flow mapping. Let's say this is the follicle. There's first going to be color flow map. Then you switch on your power angio. Then the spectral Doppler, the one that's going to give you an equal to sign, which is the sample volume. Then whichever vessel you need to insonate that, press the acquire button, and you're going to be getting a waveform on the side or top and bottom, whichever modality you're using.
And so please let me know what is the correct method to calculate the uterine artery, how to locate. Sometimes we able to locate the uterine artery, sometimes we are not. So what is the best method?
See, that's the most common question. Doc, I've been able to see the right uterine artery, but I'm not able to see the left uterine.
Yes, sir.
There is nothing like an absence of the uterine artery, that's for sure. So, and because you all do cesareans, you do laparoscopies, you do hysterectomy, so you're all well aware. But the best way to focus it on a transvaginal scan, looking at the cervix, focus at the internal os, and because the transvaginal probe is an end-firing transducer, you're going to be going like this. So you're going to be going towards the right side, towards the left side. Now the cheat code is out of the radial arteries, the spiral arteries, the uterine artery, the highest velocity is going to be in the uterine arteries. So up the scale. So the moment you go up the scale of around 30 to 40 centimeters per second, the radial and the spiral are going to vanish. They're not going to show you. It's going to be the main uterine artery that you're going to see.
How to up the scale?
There's a scale, a knob over there, the velocity,
Achha.
the moment. And for the uterine arteries, preferably use a color flow map. So when you're going to be increasing the scale, basically the scale means that anything which is, if you've made it 30, Anything which is more than 30 centimeters per second is going to only show. So the lower ones, the radial and the spiral, are going to go away. When you're going to be looking at the vascularity in the endometrium, looking at power angio, you can lower the scale. You're going to use a PRF to 0.3. But for the uterine arteries, they're one of the highest velocities. Now there's another confusion over there whether I'm insonating the uterine artery or
Yes, sir.
the iliac vessel. If you look at the uterine artery, there will never be a reversal of flow in the uterine artery. That is in an iliac vessel, which is going to show you triphasic flow. So
Yes.
you've taken away the radial and spiral. You now know which is the iliac, and now you're going to be focusing only on the uterine arteries. Sometimes what happens is the left side is a little more cumbersome. I don't know why, but it's a little more cumbersome. So you need to really take your hand more towards the patient's right thigh so that then you're going to focus on the left uterine artery.
And we have to focus on the red vessel, not the blue one. Sometimes the vessel
No, no,
appear orange also.
it does not matter. The red and the blue is basically flow towards the transducer or away. So it
Away.
could be the uterine arteries appearing as blue also. That does not matter. That does not matter.
ठीक है. Okay. Thank you, sir. Thank you.
Thank you, Jay. Thank you.
Yeah, other chairpersons, any comments from our other chairpersons if they are there? Otherwise, I think we call it a day. A lot to learn again, sir, from you. And I think the more every time we see and we, I mean, I have attended this lecture of yours so many times, but every time I find a new point to learn.
That's true. That's true.
So that is why every time I look forward to learning to re-attending the whole talk, because I know at the end of it, again there'll be something new at the end. I'll add to my knowledge. So thank you so much.
This is the one Doppler we don't usually do in our infertility fellowship or infertility training. This is the new concept. And we have been seeing that it is just correlating with the higher implantation rate. But this is one part we don't usually, this is lacking behind. So
This
we
is
want
going to make a world of difference in the practice, Ji.
Go and attend Dr. Kuldeep sir's classes. He's taking very good hands-on training also, sir, is doing. For people who cannot, maybe you have some crash courses, sir, for a day or two where
Yeah, we're having a workshop on the 29th of December. I think so. Everybody who's in the Sono School group must be aware of it. We have a one-day workshop. That's going to be on 3D. That's going to be on 3D of the obstetrics and gynecology and infertility. That's on the 29th of December.
Okay, so that is
Thank you, Kuldeep sir.
So
Thank you, Kuldeep sir, for very informative talk and your ovulation induction and that follicular monitoring, blood supply. It's very, very much useful in IUI also and better outcome. Thank you, sir.
Thank you. Thank you so much.
So thank you once again, all the speakers, right from Dr. Ladbans Kaur, Dr. Isha, and Dr. Kuldeep sir. All the you have been great, and the topics have been very, very well covered. And I'm sure all the attendees must have really benefited. Thank you to all the chairpersons who took out time and who attended and who made this webinar another successful one. And thank you so much, Jagsonpal, Dr. Deepika, and Mr. Amit for giving us the opportunity to learn. And over to you, Deepika. And I think now on the 4th of this Tuesday, we will be having the other series where up to date with updates, where we will be discussing on two journals from fertility sterility. So please join us. I think it is on 24th of December. So we would be seeing again on 24th for again a very nice informative discussion. Thank you so much. And Kuldeep sir, you can put in the details so we can share it in our groups also. Those
I'll
people
do that. I'll do that. Not a
need to
problem.
join for that one-day course. It would really be good for many of us. Thank you so much. Thank you.
Thanks, Jyoti, for your perseverance, because you said no, we have to, and that is why I was able to. Otherwise, we were going to postpone it for the next one.
Yeah,
Thank
no,
you.
no,
Thank you
no.
so much.
Thank you so much, sir. And in fact, sir was out of India. He's just, I think, last evening only you landed,
Hanji, Hanji.
and giving us time. It is really an honor to have you, and thank you always. Whenever we ask you, you are there. So that is very, very important.
Always there, Jyoti.
Right.
Thank you so much. Thank you.
Thank you. Over to Dr. Deepika.
Thank you very much. It was a pleasure having such big ultrasonologists with us today. And we thank you again. Bye-bye.
Thank you.